Welcome everyone. This is the annual Global Listening and Sharing session, which has been held virtually for a couple of years now. And we have with us here Galia Kulgor, who's one of the organizers of this great global event. And we have over 30 countries today participating through the ICD Global, the GPEG Global Listening and Sharing session. So welcome to our session. I'll just mention few ground rules. You can keep, as participants, you can keep your video off through the session if you do not wish to be recorded, or if you would like to remain anonymous. You can do not comment or within the chat during the session, or you can rename yourself as a participant. But however, we would like to see everyone on video and actively participating. So, but if it is your choice, you have the choice of staying anonymous. And so welcome to our particular session from Ethiopia. The theme of this global session is transitioning to adulthood, and we will be mainly focusing on the transition from silence to solution, navigating the transition to adulthood for children with disabilities in Ethiopia in this panel. And we have 4 panelists along with us. And I am Salaminesh. I'll be coordinating the session for you. So this session is particularly from Ethiopia. Now, I just would like to give you a little bit of background, myself originally being from Ethiopia, and why this topic is important for us, for our country. So we know that globally, 52.9 million children younger than 5 years had developmental disabilities, and 95% of these children live in low-income and middle-income countries, and Ethiopia is among those countries. And although we don't have a very good or accurate national data, we know that the risk to childhood development is very high in the Ethiopian setting. It's 60% or more, as you can see from the Lancet report here. So why we named our topic of discussion today silence to solution. I will just give you a little bit of background what the silence was. And as a developmental pediatrician from Ethiopia, I had been observing a lot of the childhood disability care and the unfortunate circumstances we pass through, and we have many children who had been under the care of their parents and completely dependent on parents not having access to many resources or services. And as you can see in most of these pictures, the mothers are carrying the child. And I wonder what would be the transition for these children as they get older, or as the family passes away, or the mother, who is the primary caregiver, cannot any longer be strong enough to do all the things that they are doing currently. And this is a patient I had been following when I was in Ethiopia, is a 10-year-old male child who was diagnosed with autism. And as you can see, his hands are tied behind because he has a self-injurious behavior, and he keeps hitting himself. So this was the only way that his caregivers were able to prevent the self-injurious behaviors. And he was on a cocktail of different medications. And I wonder what is the transition like for this child? How would his life be as he transitions out of his family to other cares? And what is the service looking like in Ethiopia currently? So there are some enlightening lights that I would like to share with you. There is a developmental pediatrics field which is growing in Ethiopia. And as most of you know, I am the first Ethiopian developmental pediatrician, but not the only one currently, as I have many followers currently, and I'm very proud to say that there are many people who care for children with disability, and you will meet many of those advocates in this panel today. So I would say we are in the path of proper evaluation with history, physical examination, early identification using early identification tools, engaging in national education, teaching our professionals about childhood disability care, and contacting some of the rehabilitation centers available and making those links. And still transition to care would remain a big question. And looking at this ICF model, which is the core of care in childhood disability, you can see that the future is what we are worried about, or what we will be focusing on today's panel. So with that, I would like to introduce you our panelists for today's session. Our first panelist would be Dr. Abraha Regzaber. He is a pediatric neurologist from Mekelle University, and Dr. Abraha is the Chief Clinical Director at Eider Comprehensive Specialized Hospital, Mekelle University in Ethiopia, and he's a pediatric neurologist committed to advancing care for children with disabilities. He has led efforts to strengthen pediatric neurology and rehabilitation services in resource-limited and post-conflict settings. And Dr. Abraha's research has provided critical child health, maternal, and critical evidences in disability prevalence and healthcare system collapses, mainly in the Tigray region. His work informs strategies for restoring services and improving continuity of care for children with cerebral palsy, autism, epilepsy, and other neurodevelopmental conditions. As a mentor and advocate, he champions family-centered approaches and transition planning for adolescents with disabilities, ensuring that recovery efforts prioritize inclusive and sustainable care. We are honored to have you, Dr. Abraha, today. And our second panelist is Dr. Bahailu Yebe, who's also an assistant professor of pediatrics and a pediatric neurologist at Addis Ababa University, the College of Health Science. Dr. Bahailu is a dynamic educator and clinician committed to advancing equitable medical education and improving care for children with epilepsy and childhood disabilities across Africa. Dr. Bahailu has led pediatric neurology services, coordinated undergraduate medical education, and championed curriculum development and simulation-based learning. He currently serves as the head of the Pediatric Neurology Unit, board member of the Ethiopian Neurology Association, and founding fellow of the East Central Southern Africa College of Pediatrics and Child Health. And his professional interests focus on epilepsy, childhood disability, and innovative educational strategies to strengthen pediatric care and training in resource-limited settings. We're very delighted to have you with us, Dr. Bahailu. And our third panelist is Dr. Azadeh Teklai-Mahanot, who is an assistant professor of pediatrics and child health and head of the developmental and behavioral pediatrics unit at Tukur Ambassa Specialized Hospital in Addis Ababa. She also serves as honorary assistant professor of public health at the Addis Continental Institute of Public Health. She's a passionate advocate for children with disabilities, dedicated to advancing early identification, quality of care, and inclusive services through clinical practice, training, community engagement, and research. She's also the founding fellow of the Early Childhood Development Team of the Eastern, Central, and Southern Africa College of Pediatrics, and actively involved in neurodevelopmental research projects and advocating for early childhood development and developmental and behavioral pediatric challenges. We're very delighted again to have you, Dr. Azadeh. And last but not least, our fourth panelist is Dr. Kalkidan Tesfaye, who is a pediatrician and clinical coordinator for the Department of Pediatrics and Child Health at St. Paul's Hospital Millennium Medical College. She leads the hospital's developmental clinic, where she is committed to promoting optimal child development, early identification, and improving care of children with disabilities. She's a passionate advocate for inclusive pediatric services and has supported numerous families through developmental assessment, counseling, and multidisciplinary care. Dr. Kalkidan is also a Mandela Washington Fellow and Star Scholar, experiences that strengthen her dedication to servant leadership system improvement and advancing child health in Ethiopia. Beyond her clinical and leadership roles, she volunteers with organizations focused on improving child health and well-being. She's also an active content creator using digital platforms to raise awareness and advocate for child development. Very honored to have you, Dr. Alkidan, as well. Thank you so much, all of you, for being here. Now I will proceed with the panel. I'll stop sharing my screen so that we can see the panelists and have a discussion all together. Great. Thank you all for being here, and thank you for our audience for joining us. Okay, so I'll just start with a question that relates to what I have been setting the ground for. What does transition to adulthood currently look like for children with disabilities in Ethiopia? Is it even a concept that families or providers talk about? And I'll just hand the button to Dr. Abraha. Thank you for joining us. Do we have Dr. Abraha or not yet? Okay. So I will just pass it on to Azadeh if you would like to start the panel by answering this question. Thank you.
Thank you, Dr. Salamanish, for the introduction and also for the initial ice-breaking presentation also. So for the question that you raised, what I can say is that this concept on transition to adulthood for children with disabilities is, we can say, in the infancy stage or still emerging in Ethiopia, and it doesn't have a clearly defined or it's not widely practiced process. So for many of the parents or caregivers of children with disabilities, the focus is always on the basic survival, on the healthcare, access to education, and daily support for their children. And when the child reaches to that age of adolescence and early adulthood, usually there is a significant gap in services and also guidance how to go about it. And so I think there is a significant big gap in Ethiopia, and usually the pediatric systems focus on the early childhood age, and the adult systems usually are not prepared to receive these young people on even ongoing developmental and physical disability follow-ups. Also, they sometimes even have challenges where to follow up, and let alone on the idea of transition to adulthood and seeing it in other aspects like the social aspects and also the job aspect. So even the terminology is not that much used formally. So, but we all know, the families know, the providers know deeply the challenge. We're aware of the challenges these children face in the adolescence age and in early adulthood, even losing follow-up and also limited opportunities for vocational and different jobs, and stigma on top of this also makes it worse in Ethiopia. And there is awareness. The fact that we're discussing about it today is also one way that to increase the awareness. And then the next part would be we can work on. We will discuss later on. Also, the other issue would be changing this awareness to action would be the next step. So there is a growing awareness on this line, but we need to work on that. And it's still the conversation is beginning and we have to move this part, and that's what I can say on the current status in Ethiopia. Thank you.
Thank you so much, Azadeh. That does enlighten us very well, and it's very promising for me to hear that the conversation is starting. Thank you for highlighting on that. I know Dr. Abraha has joined us. Dr. Abraha is also the Chief Clinical Director, so he was on duty, and he joined us late, but we're just yet at the first question, but I'll give you a minute to take your breath, and I'll just redirect this question to Kalkidan if you have anything else to add, or in your practice in your developmental clinic, if you have seen these conversations being started as well.
Yeah, thank you very much for the warm welcome and for the warm introduction, Dr. Salaminish, and thank you all the panelists. It's an honor to be here with this distinguished panelist. So as Dr. Azada said, I second her most points. There's no, in our clinic and during our residency and practice, so there are no clear standards to transition to adulthood, and the transition is often informal and under-resourced, and mostly it's left to families because the families, they don't usually know where to go, specifically for healthcare, rehabilitation, even education. There's no clear structured standard and pathways so that the children can transition from pediatrics to adulthood, as you have clearly stated in your presentation. So this rehabilitation and advocacy regarding children with disabilities coming now. Most clinicians are inclined to this field. So now I think the silence is breaking in the field. So it's just at the infantile stage. Even in our setup, we don't have a clear pathways to refer to adult centers. And even regarding the rehabilitation of children and different therapies, we don't have a clear referral system. So still at the infantile stage. That's what I can agree on.
Thank you, Kalkidan. I see Dr. Abraha, you have unmuted. If you would like to add, we can give you a few.
Thank you very much, Dr. Saliminish and all my colleagues, national and global. Thank you also for the opportunity. Yes, it is a challenge, generally visible, and then of course I second also to my colleague Dr. Alkidan raised, left to families usually. So where do you prefer is usually the question that comes to parents, particularly when children and adolescents are affected with disabilities. There is a general empathy by the healthcare workers, general sympathy also by anyone around, and that makes them flamboyant. In fact, you can go whichever you wish is not also always a good answer. So it has struck our minds and came also to a point of discussion in our setup with colleagues. And would a system-based approach be better? For example, neurosciences together, cardiology together is one of the way my colleagues raise and discuss. So it kept to be extremely flamboyant, and then I am happy it came to be a discussion, and then also we are part of the hearing with the listening and sharing. Thank you.
Thank you, Abraha. And I know we all know that it's one of the biggest challenges we face in the care of childhood disability wherever we are in the world. And I would like to say it with an example. And Dr. Bahailu, if you can share a story or an example of a youth with disability who faced challenges during such transition phase. What could have helped, and with that we could say to discuss a little bit about more solutions.
Yeah. So thank you very much for this opportunity and the kind introduction. I second what my colleagues have been saying. So to make it in story form, I have an example of 15 years old female. She has been on follow-up at our neurology clinic. During the follow-up, we were only emphasizing about the seizure control. So the seizure was started around the age of 12. We give her anti-seizure medication every now and then. We ask her about the seizure medication. So apart from the epilepsy, she has some mild form of intellectual disability. So for long, she disappeared from the follow-up, and after 6 months, she came with her mother. So when she present, we noticed her belly is a little bit bigger. So we asked the resident, and I asked the mother. The mother said she is pregnant of 4 months of age. So during our career and our teaching practice, we have been teaching about how to use valporate in pregnant women and so. But during the follow-up, nobody was considerate about her possibility of being pregnant, no education about reproductive health. So this is not the area where the families are only afraid of. As a physician, we have a fear. Since we can't navigate where the family to go, we tend to reserve to raise such a question. So the child is pregnant. We were really shocked. We tend to uh, we tend to clear the room, making the other families to go out of the room, and we seated with the family and the child. We asked the duration of the pregnancy. Now it is 4 months. So changing anti-seizure medication, stopping it becomes more challenging. So since we were not prepared, we have to figure it out in that setting. So we continue the medication, and after 9 months of pregnancy, she delivered a child. She's now 15 years old, still on follow-up. The child is being taken care of by the grandmother. The grandmother has been the one taking care of this child, and now she is also taking care of her granddaughter. So I would say this is the case that pop up in my mind. But there are lots of cases when they grow in size, when they grow uh, in ambulation, especially children with autism spectrum disorder. So the families are afraid from the outset, what would he become when he grows up? And as a physician, we are also afraid what he will become when he grow up and not cooperative. So this is an area where we don't have any map where to go. It is a dark area for the parents and also for a physician. Thank you very much for raising this issue as a point of discussion. I think we will figure out some ways in our discussion. Thank you.
Yeah, thank you so much, Pahelu, and that gives us a really good insight into how far unintended or unattended concerns could go, and not planning the transition of this child. We see that what it has costed the family, and also her in terms of like her future child as well. And from your experience overall, if you would like to summarize on the most pressing concerns that families usually state as their children are getting older, and with that we can set it to discussing what other practices or informal models you have been following in clinics or in your practices to address some of these concerns. We can start with you, Bahailu, and I will let Abraha take on as well.
So when the families are asking us where to go, we tend to send them usually to adult clinic. So I have one patient, she's on follow-up in clinic. She has hemiparatic TP, and she's attending grade 12. I send her to adult clinic because this is the only output we prepared to do. She went to adult clinic. When she goes there, she came back and told me that all of them are old people. What am I doing there? She used to be in our clinic, and she's better accustomed with that. So the traditional ways, not anymore to carry those patients with disability. So I would say just transferring to other areas where we can't intervene and have another option. So we are transferring to the adult caring clinic.
Okay. So one strategy is transitioning to the making sure that they have a link to the adult clinics, or there is someone to look after them as they are older and not under the care of pediatrics. Thank you, Bahailu. It's Abraha, if you would like to ask if you would like to add if there are other models or informal practices you have been trying to do in your practice or in your hospital as well.
Okay, thank you very much once again. Parents are very keen about the changing behavior when these remain with us and as adolescents. So autonomy and then not mixing with others, for example, and becoming part of the decision making, and privacy and shyness. These things completely come changing, and I have also opted some patients who are now 19 to link them to the medical neurology for concomitant with the cerebral palsy having epilepsy, and then some of them cry. We don't want to get introduced to some other colleague, and most pressing again amongst care providers is my child, now adolescent or growing adolescent, going to be in any way an independent adult is a pressing concern, and then our approach shall be built up this way. One of good examples I don't forget working together is better on this adolescence is that my colleague practicing in medical neurology met a 14 years old adolescent boy, and then he observed some motor symptoms, and one intrigue, peripartal and early infancy and childhood, early toddlerhood was okay, but later developed some abnormal movements, and then particularly the recent years is going disabling. And then he called, my colleague called, and I'm observing a funny cerebral palsy. Abraha, what is this? And then we agreed to see him together. And then the observation was features were dystonia. And then, okay, this is an adolescent that has acquired dystonia. And we give him a try of Diopa was our discussion, and then offered him Dopa. And he dramatically responded. It was very gratifying in two instances. One, the collegial work together on an adolescent, a medical neurologist and a pediatric neurologist working together. Second, the life of the boy has completely changed. And then it reminded me of, again, a 22-year-old young man. I saw him during my fellowship because the first year is general neurology that we do in the Blackline Hospital. This is again another man with dystonia and unattended living in Addis Ababa. He was excellent, intellectually okay, and always performing good whenever the teachers give him space. But during the matriculation exams, for example, 8th grade, he couldn't pass. You remember Amat, or our local language in Tigrinya, I mean in Amharic. So the exam is in all multiple choices, having 5 boxes for each question. So A, B, C, D, sometimes E, and then there are small boxes corresponding to the number, so then to the ABCD in the columns, and the number is cited as a row. So it is just as a box that he has to paint with a pencil. This concise movement, this fine movement was difficult for him, and then who couldn't pass the 8th grade despite his performances. I saw the earlier certificates. He was scoring 80% and above. So this is what we are missing, and again, an independent livelihood is one of the pressing issues among his families. Thank you.
Thank you so much, Abraha. That really highlights how there is no specific systemic plan or services as well, even including in terms of like the educational services to accommodate the need of these children as they transition to autonomy and would like to be doing more things by themselves more independently. And just looking at since I know Dr. Kalkidan and Dr. Azadeh runs the developmental clinic, and you will be seeing most of these children and families, and we know that from my experience as well, most families, the things families would like to talk about and the things we focus on, there is a lot of disconnection in between. And so in your opinion or in your practice, what have been the biggest barriers to implementing some of these services in Ethiopia? Azadeh, you can go ahead.
Okay, that's important question, because when you know the barriers, we can start working from that to improve this transition to adulthood. So one of the barriers that we can mention is the health, the education, and the societal systems in the country are not that there's no linkage or that a system where you will know where a child with developmental disabilities at this age, you should link him to this clinic, or you should send him to this school or to this social service. So there is no link in that line. So pediatric care ends abruptly in adolescence, and the adults are not ready to take those adolescence ages, and those adolescent children with disabilities usually fall through those gap cracks. And the other is limited awareness and training. As we were saying also, it's not, the awareness issue is not only on the side of it's not only on the side of the providers, but also on the policymakers, the families, and the clinicians, and anyone giving care for these children doesn't have the awareness, and how a way also to improve this care. And the other is resource wise also, the system, different resources, human resource in this line of work. There is limited training in this in children with developmental and behavioral issues as a whole, not only in this age group but also in the earlier age group. There is a big gap. So this resource and human resource, as well as transition care, requires time, coordination, and also interdisciplinary collaboration. So that's constraint is another barrier. And the other is societal and cultural factors. We can say stigma is a big challenge. So that also affects the families, as well as this happens also on the side of the policymakers. And this all can be linked also because of limited awareness and on this area. This can be some of the barriers I can mention. Kalkidan can add more. Thank you.
Thank you, Azadeh. And Kalkidan, if you have anything to add on that, and with that, if you can highlight a little bit more on what feasible small steps can be taken within the existing systems to begin addressing some of these transition needs as well. Thank you.
Yeah, thank you again. So Dr. Azadeh has mentioned most of the barriers while dealing with this transition. Just to add few points. The first one is there are several systems that are being implemented, but still the system is fragmented and poor coordination regarding that area. So I will try to answer each system that we are trying to do with regarding the buyer. So trying to solve this problem. So before there was no even awareness regarding this. The clinicians even don't have any awareness, starting from the residents to the seniors. We don't actually have a clear understanding of this. So we're trying to advocate through social media. We're trying to teach the public as well as our colleagues and our residents regarding early detection of children with disabilities, and even creating the atmosphere about there are several interventions being done, because in our setup, most of the children, once they're diagnosed, even the clinicians don't want to keep following, and they're not focused or they're not giving them multidisciplinary care. So the first thing is we have created a network of expertise in the nation. So this platform, I think it would be a great opportunity for all of us to collaborate and work together. We can call among ourselves so that we can collaborate and take expertise. I know we have a lot of limited resources, but I believe that we have a resourceful hearts and minds. So I think this would be the first thing. The other one is we have a limited pediatrics and adult rehabilitation centers. So currently at St. Paul, we are working with partners regarding rehabilitation. So along with your partners and ours, so we are starting to give seminars for the residents so that they can be aware. So we have implemented, last week we had one session for the seminars so that they can have a global perspective that this is being done for these children. So we need to implement this in our setup. So the first thing I would believe is creating the atmosphere and the awareness for this care for the children, then we can go step by step. Regarding rehabilitation, the other thing is there are centers that are as a government level and as other private sectors, they're opening rehabilitation centers for these children, even though it's not well equipped and it has a lot of limited resources, but we're working with that so that we can have a clear center for these children. So the other is regarding the education system. So now it's being advocated still, but we have weak inclusive education system. So this children having special needs, they don't have a clear way to go, even within the clinician, the policymakers, the societies, they don't work hand in hand. So these platforms will create a network of collaboration so that we can advocate and work together to build a sustainable system for children with disabilities in this area, so that it will help them to have a clear transition for these children.
Thank you so much, Alkidan. You really highlighted in very important points, and I do think these are not really big steps. It's not we're not really talking about changing a big policy or building an infrastructure, but you both highlighted on the awareness creation for providers, families, policymakers, as well as those interdisciplinary collaboration in working together with the adult services that we do have available currently. And you've raised an important point on inclusive education as well. With that, I would like to ask because I know Dr. Abraha and Dr. Bahailu, they have a great passion into medical education and also advocating for awareness. How do you think medical education and training programs in Ethiopia could help in the development of these transitional care principles? And I would start with Abraha.
The current discussion also reminded me of when I chose pediatric neurology, and then I showed also some of my colleagues raised when you recall in the Black Lion Hospital, the third years, we have specialty attachments. Sometimes the chief residents, you can negotiate where to go. So neurology was one of the unliked specialty clinics, and then one of my colleagues, are you inclining toward disease? And are you specializing to tell the prognosis? This came from a colleague that was graduating as me, as a pediatrician. So knowledge is so important that I would say knowledge emancipates us, knowledge enables us. And the time we had very few pediatricians, for example, amongst the child with disability, cerebral palsy has been completely neglected. You diagnose and then send them home. But with time, there is understanding, and then comprehensive response to the condition is coming up. The war disrupted our condition. Otherwise, when I came back trained in pediatric neurology, by then the leader of the hospital, chief clinical director with human resource management, for example, were able to listen to me, and then we recruited 2 speech therapists, speech and language therapists at that time, for example. So the physiotherapy, the head of the department, was inclining towards pediatric physiotherapy and pediatric and neurological conditions. So fertile ground was forming. So and one of the topics we chose, for example, number of topics on neurological and developmental conditions were amongst research thesis. One of them we saw, for example, the determinants of or risk factors for cerebral palsy, for example, amongst the visitors that year, 2019, for example. So as far as we build on greater number of pediatricians and then better developmental pediatrics as a specialty, pediatric neurology as a specialty, this will guide us to a betterment in terms of one, disseminating the knowledge to undergraduate medical education that yes, rehabilitation, therapies, interventions determine the future of these growing children. And then as adults, we can contribute so significant towards the independent adulthood. Second, evidence-based decisions. On recent discussion, Salam, you were leading, for example, discussion about data synthesis regarding, for example, cerebral palsy. So now people are coming to the sense that we can synthesize data for decision making. And certain lectures, thanks to you also, Dr. Salaminesh, again. Recent, for example, trainings amongst the postgraduate trainings in pediatrics and child health are getting better understanding of developmental pediatrics. And this makes a lot of improvement in the approach towards these children, these needed children. And back to the early childhood also, Al-Kidan has raised so valid points. So thank you.
Thank you so much, Abraham. Yeah, I think everything starts from learning from each other, and that's also the purpose of this session, why we are having this panel today as well, so that if we can grab 1 or 2 attention into this transition of care and come up with a global partnership on how to proceed in establishing some of this transition care within the clinics that you all are running. That would be a great outcome from this panel. Bahailu, I'll just pass the button to you, and you can highlight a little bit points on medical education and how that could improve the transition care principles within Ethiopia as well.
Thank you very much. So we have a change in over a period of time. As Abraham said, when we are young students, we know how cerebral palsy reacts of certain factors. With time, with awareness, the number of physicians included in the field of neurology and disability, there is much improvement, at least in understanding. So one of the areas that residents of referral from other regions of the country coming to the neurology clinic witness how we are making the family the center of care for a child with disability. So most of the cerebral palsy conditions are lifelong condition is changing over a period of time. So one of the things we are doing in our clinic is empowering the parents of how to care their child and giving them awareness about the disease condition. Subsequently, most of the residents are surprised how the families are understanding and even sometimes better than the physicians or the residents explaining things to the back to the physician. So one of the areas we should improve is, or we are working on is improving the care of the patient, and making and empowering parents about the care of their child. So this is one area as educator we have been working on. Another important area as a teaching hospital in our Tukrambasa specialized hospital, I have been contemplating after having this topic of discussion. So most of the time we tend to think how to divide the clinic days. Like we work 5 times per day and we tend to divide the clinic, seizure clinic, CP clinic. But after having this topic in my mind, I was thinking, what about making the clinic based on age, especially grouping them from 12 years of age and above, assigning one day for all of them, so that we might have an opportunity thinking about their transition and also involving other fields like psychology and psychiatry in communicating and understanding these parameters. So as a teaching hospital, and also this will be a message across the country how we see, involve, and change transition care in the country. Thank you very much.
Thank you so much, Bahailu. That is what a great idea. What a great idea to dedicate a half day to these children who are transitioning and are at that stage of life that families are being worried about, and care providers are not giving much attention for all the challenges that you guys have shared. With that, I would like to open the discussion to our audiences as well. So please feel free to ask your questions to our panelists, or please do share if you have a certain a model that you have seen have worked or that you wish you could have adopted. So please feel free to put questions in the chat, as well as raise your hand or unmute and speak. We would really love to hear your opinions as well. So while the audiences are thinking about their questions, I see Galia, you are on. Did you have any comments or questions?
Just wanted to say thank you to everybody to share your stories. So interesting. I just wanted to sort of think in the future, you know, how many years away in the future do you think you would have services established that you know would be your dream service? You know, how long do you think that would take, and what would it look like if you know had the ability to do what you wanted? What would you see that being?
Thank you, Galia, for that question. That's a very important question. Yes, and I'll love if the panelists can take all of them, can tell us what one thing they would like to change tomorrow, if they could. What would that be? Azada, you can go ahead.
Yeah, thank you. If I could change one thing tomorrow, I think I was thinking also some way it's this gap is not only actually in children with disabilities, also the adolescence age is somehow left out in our country. So one thing is to formally recognize this transition care and also the adolescence, and that would make a big change if that is included in the policy, and that would open the doors also for guidelines, manuals, training in this regard, and that will also be including the transition care clinic Dr. Bahailu mentioned about also. Thank you.
Good. Excellent. Thank you so much. Galkitan, you can go ahead.
This is one of the most challenging and interesting question. It was personal question for me as well. So what I would want to see, the first thing tomorrow, if I want to change, what I want to change tomorrow is the first thing is I want to create a team of passionate people, because the children with disability is not like the other sectors, because it needs passion. it needs care. So a team of people that will advocate for the nation's policy, because most of the things that we were discussing previously regarding policy, regarding subspecialty trainings, regarding clinics, all of them, they need a team of people to work with, and a team of collaborative teamwork that need. So the first thing I want to see is this team of people advocating and moving forward. And to answer for Gala's question, so I want to see a center where children with disability, families especially, are not stigmatized, are not left over, because even in our practice, once diagnosed, they're not even being followed sometimes. So I want to see this rehabilitation center being open to, especially for pediatrics, focused on pediatrics only, so that they can have organized, structured center where they can have OTs, speech therapy specific centers. Of course, they are fragmented, but I want to see this in the coming few years, 5 to 10 years. I want to see that, even if it takes more than that. I really want to see that in my lifetime.
Thank you so much, Kalkitan. That's a very beautiful wish, as well as thing that could practically be implemented as well, with all the dedication of the team leaders that we do have here and others who have not joined us. Vahailu, you can take on to share. I know you've mentioned your great idea, but you can highlight on that and add.
So, Gela asked important question. What you would wish to see? So this question, since I have been so much consumed by the difficulty, I didn't get to imagine what should I would see in the future. But I would say on Monday, when I go to my clinic, I see a team of physicians, orthopedicians, occupational therapists, speech therapists, neurologists sitting together in one room, seeing a challenging or a child with disability, having to make a plan together and having follow-up those children. So creating a multidisciplinary team, having certain plans for a given child so that the parents and families can follow along with them. So when we create the team, we need to also provide areas where those things could be executed. So if I see that, that would be very good. Thank you.
Thank you, Vahailu. Yeah. And Dr. Abraha, the last and the most important remark.
Thank you very much, and thank you also for the for the kind question that basically is an encouraging moment to take up. So by tomorrow, that I feel is less Monday or Tuesday, I will sit with the head of Department of Internal Medicine, at least Internal Medicine and Pediatrics, to share to them my feelings. How is our transition going on? So they will take some days to come up, listening to residents of internal medicine, residents of pediatrics, and the experience of the consultants in each of the two departments as entry points, and formulate a way forward. And one of very interesting approach Bahailu has raised is interesting. I would consider. Then my ambition is to formulate and find a well-versed multidisciplinary team that contributes to the independent livelihood of children affected with disabilities. Thank you very much.
Thank you so much, Abraha. And I want to make sure we answer Dr. Delahun's question as well here. Does establishment of adolescent clinic help transition, the transition principles conducively? I think that's what you meant, Dr. Delahun, or you can correct me. Anyone who'd like to take on that question? Does establishment of adolescent clinic help transition?
I think yes. It's one of the areas. For example, Bahailu reported of an adolescent who conceived, and then recent day I saw a girl that was a teenager she was married and then having spontaneous abortion. For the follow-up, she was in pediatrics for the pregnancy and related. She went into a medical ICU. Very confusing for her. Very, very, very confusing. So yes, an organized adolescent clinic will partly solve the problem, and it will contribute to the amelioration of the attendance of the transition of these adolescents affected with disabilities. Yes.
Yes. Okay. Thank you. And I would say like today is an opportunity to learn about some of those models because we have over 30 countries sharing their experiences and what have worked for them, what has been the challenge. And you will hear from the most successful centers. You will hear from the most innovative centers who didn't have a transition clinic but had created their own models as well. So please continue to join us. I'm being worried of the time, but I also know we started 5 minutes late, so I'm just using my own power. Forgive me, Galia. So I see a comment from Samahal. It's very heartwarming to see how the care for people with disabilities in Ethiopia is moving in the right direction. Thank you. My question is, how do you see this care expanding beyond the big cities? And I think that brings us back to the point that Galkidan was mentioning earlier, having that team of passionate people. And Galkidan, if you would like to comment on this, that would be great. How do you see it expanding beyond the big cities?
Yeah. So for personally, for me, when I started this, so during my residency, so it was the place where I see developmental clinic because there was no, it was a Black Line. Then after that, we established in St. Paul Hospital. This is still big cities, but what we're trying to do is we're collaborating at Yekatit Hospital, now Adama Hospital. So there's one pediatrician who will be going for fellowship of developmental pediatrics from Adama. So I think this group of network of pediatricians will go and will share their experience, they will share their trainings, and this will keep expanding, not only in the central Addis, but also at the Oromia region. And now we're trying to find pediatricians, even residents in the southern region. So we are also working in other projects together, this expertise. So I think this will create a network of people among ourselves so that we can work on children with disabilities and expand this work.
Thank
Yeah.
you. Yes, Agata.
To just add a few points on this one, the other way that we can expand this thing is that on the education aspect, when you train the residents and create the awareness and advocate with them, these pediatricians are going back to different cities in different countries. So one way is you might find people interested in this area, and the other way is they could pass the knowledge and the awareness also to the big cities.
Thank you so much, Azada. We do have a lot of great comments from Dr. Yasin as well as Marushat as well in the chat. I will let you read them just for the sake of time. But I am very happy that we have had this discussion today. And I would say we have the right ingredients here. You all mentioned 4 important things. And I do think like you are the leaders of these clinics. You are the leaders of big hospitals, major tertiary hospitals that others would take as role models. So I would say by Monday, start working on the transition clinics that you all wished for, because we start with very small steps, and all the global partners, the IACD, and all the GPIC team is here with you. We will be very happy to support, and of course, as colleagues and friends, you always have access to me as well. And we do have those team of passionate people Kalkidan was talking about, and we have them all over the world. We have them all over Ethiopia as well. Let's make use of those people and creating that multi-D team that Bahailu and Abraha were mentioning will not be very hard, being in a major tertiary hospital. So let's start with the small steps. I think this this is a great start, and it was very lovely having you all here and learning from you, hearing your perspective, and thank you our audiences for your active participation as well. I will let you go so that you can attend all the other amazing programs running through the globe as well. If I can have the panelists remain, the rest of the team can leave. I'll stop recording now.
Thank you all. Thanks, Salamanish. It was a really great session. Have a lovely day.
You too, Galia. Thank you.
Thank you.